Dear colleagues, in partnership with Nephrology, Dialysis, Transplantation, NDT, the official journal of the European Renal Association, Marcus at Home welcomes Professor Mårten Segelmark in Lund, Sweden, Professor Lisa Willcocks in Cambridge, United Kingdom, Professor Bradley Dixon in Aurora, Colorado, USA, Professor Fernando Fervenza in Rochester, Minnesota, USA, Professor Gregor in Vienna, Austria, Professor Hiddo Heerspink in Groningen, the Netherlands, and Professor Brendon, normally in Sydney, New South Wales, tonight also in Groningen, the Netherlands, to discuss the arguably most important late-breaking clinical trials from this year's ERA meeting. Dear Mårten, dear Lisa, dear Fernando, dear Gregor, dear Bradley, it's a pleasure to host all of you.
We are delighted to welcome such an outstanding group of guests today who have kindly agreed to share with us once again the results they recently presented at the ERA Congress in Glasgow. We are pleased to be joined by Professor Bradley Dixon from the Department of Pediatrics, School of Medicine, University of Colorado, United States, with whom we will be discussing the COMMUTE-8 study. Professor Mårten Segelmark from Lund University, Sweden, will join us to discuss the Good Ideas O2 study. Professor Lisa Willcocks from Cambridge University Hospitals NHS Foundation Trust United Kingdom will share and discuss the results of the TURING trial. From the Mayo Clinic United States, Professor Fernando Fervenza will provide insights into the Majesty study. We will also be speaking with Professor Gregor, Medical University Vienna, Austria, about the TTV-guided study. And also joining us are Professor Hiddo Heerspink from the University Medical Center Groningen, the Netherlands, and Professor Neuen from the George Institute for Global Health, Australia, who will discuss the FIND CKD. We have pre-recorded these presentations in advance. As co-moderators for today's session, we are delighted on behalf of the Marcus at Home team to welcome ERA President Professor Rosa Torra and NDT Editor-in-Chief Professor Hans-Joachim. We invite you to join us for an exciting journey through some of the most important highlights from this year's ERA Congress.
And we will start with a pre-recorded discussion on FIND CKD.
So it's a great pleasure for us to welcome for the first time Professor Hiddo Heerspink from the Universitäre Medische Zentrum in Groningen and Professor Neuen from the George Institute in Sydney to talk about finerenone. We all were in Glasgow and we saw a packed room with 3,000 attendees and a lot of applause when the presentation actually was midst and the results were presented, and we are very glad that Hiddo is presenting the main results and Brendon is then moving on to the glomerular disease subpart and what that means for us as clinicians and how we implement finerenone in our clinical practice. So Hiddo, the floor is yours.
Thank you very much, Andreas, for the introduction and for giving us the opportunity to present the data here. For those of you who were not able to join us in a beautiful meeting in Glasgow, there was a great enthusiasm all days long. Lots of new data, new science, very exciting. And the meeting was extremely well organized. And it shows us that the ERA-E meeting is becoming more and more important and more interesting over the years. So we were in the fortunate position to present the FIND CKD data, a clinical trial that we started 5 years ago using GFR slope as the primary endpoint, also reflecting the progress we have made in the development of clinical trials and the new endpoints that we can use nowadays to assess the efficacy of new interventions for patients with chronic kidney disease. We know that around the world, approximately 800 million people are diagnosed with chronic kidney disease. And although diabetic kidney disease is the most common single etiology of chronic kidney disease, we also know that there are many patients who live with non-diabetic kidney disease. And non-diabetic kidney disease comprise a range of different etiologies: glomerular disease, vascular disease, disease of unknown etiology, tubulointerstitial chronic kidney disease, or chronic kidney disease due to infections or obstructive disease. Traditionally, there has been a lot of emphasis on diabetic kidney disease, and that has led to new interventions, but we also have to develop new therapies for patients with non-diabetic kidney disease. So around the world, approximately 400 to 550 million people who live with non-diabetic kidney disease. And here you see the advancement in the treatment of diabetic kidney disease, now 4 pillars on top of comprehensive lifestyle and risk factor modification, among which finerenone. And we asked ourselves the question, can we also use finerenone in people with non-diabetic kidney disease? Because as you can see, there's much less evidence for new therapies in non-diabetic kidney disease. So the house and the roof of the house is not as stable as it is for diabetic kidney disease. And we need additional pillars to stabilize the roof of the temple for non-diabetic kidney disease. So the question is finerenone also effective in people with non-diabetic kidney disease? We know that mineralocorticoid receptor overactivation is common in chronic kidney disease and is implicated in disease progression. We also know that in diabetic kidney disease, finerenone has proven efficacy and safety. In the Fidelio and Figaro diabetic kidney disease trials, finerenone reduced the risk of kidney failure, cardiovascular disease events, and reduced the rate of kidney function decline. We know that overactivation of the mineralocorticoid receptor is also present in non-diabetic kidney disease, in glomerular disease, tubulointerstitial disease, vascular disease, and thus could finerenone also slow disease progression in people with non-diabetic kidney disease. So the aim of the FIND-CKD trial was to investigate the efficacy and safety of finerenone in addition to standard of care on the progression of chronic kidney disease in people with non-diabetic CKD. So we enrolled adults with a GFR between 25 and 90 and significant albuminuria. They were all using standard of care, including a maximal tolerated dose of an ACE inhibitor or angiotensin receptor blocker. And we excluded people with diabetes, either type 1 or type 2 diabetes. We excluded people with symptomatic heart failure with reduced injection fraction because other MRAs are indicated for these patients. At the time of the design of the trial, we felt that patients with polycystic kidney disease, lupus, ANCA-associated vasculitis would probably not benefit of finerenone because we don't know about the role, whether MR, the mineralocorticoid receptor, is overactivated and plays a role in disease progression in these patients. So we designed this clinical trial using GFR slope as the endpoint. So the rate of GFR change over time, over 32 months, was the primary endpoint. So after randomization, people were followed for 32 months and people were treated with finerenone 10 or 20 milligram once daily versus placebo. This endpoint, GFR slope, is now accepted by regulators and thus we can use it, and that can thus decrease the sample size. If we would have used a traditional endpoint, we probably would have needed 5,000 patients and it would have led to a much longer and more complex clinical trial compared to GFR slope. So we wanted to bring this drug quickly to patients, and that's why we use GFR slope as the endpoint. Now the trial was designed to assess an effect on the total GFR slope of 0.7 mils per minute per year. So we had expected that we would find an effect of 0.7 mils per minute per year. And based on large meta-analysis, we know that this will translate into a relative reduction of 23% in the risk of adverse kidney outcomes. So we enrolled 1,584 patients. Their mean age was 55 years. About 2/3 of the population was male, and the majority came from Asia, where non-diabetic kidney disease is particularly prevalent. The mean GFR is 47 mils per minute, median UHCR around 800. So these patients are at high risk of disease progression. Nearly all of them were treated with an ACE inhibitor or angiotensin receptor blocker. 17% were treated with an SGLT2 inhibitor. So during follow-up, we found that the GFR declined by 4 mils per minute per year in the placebo group, reflecting the high risk of this patient population. Now, in the finerenone group, we saw an acute reduction in GFR followed by stabilization and attenuation of the GFR slope compared to placebo. The mean eGFR decline in the finerenone group was minus 3.3 mils per minute per year, resulting in a 0.7 mils per minute per year difference compared to placebo. So we expected a 0.7 mils per minute per year difference, and we found a 0.7 mils per year difference. Now, after discontinuation of finerenone, we observed that the GFR increased by 1.2 mils per minute per year in the finerenone group, and it decreased by minus 0.5 or decreased by 0.5 mils per minute per year over the 4 weeks in the placebo group. So the initial reduction in GFR in the finerenone group is reversible after treatment discontinuation, even when you have treated these patients for about 3 years. So the effect of finerenone on the total slope was 0.7 mils per minute per year, and the total slope comprises the acute effect and the chronic eGFR slope. And here we break down the total slope into its acute and chronic components. Finerenone would acutely reduce GFR over 3 months by 1.2 mils per minute, and then the chronic slope calculated from month 3 until the end of treatment was reduced by finerenone by 1.2 mils per minute per year. So there is a clear effect on the total chronic eGFR slope. The effect of finerenone on the total GFR slope is consistent across pre-specified important subgroups. So finerenone reduced the total GFR slope irrespective of whether patients had hypertension, ischemic nephropathy, chronic glomerulonephritis, or an other chronic kidney disease. Effects were also consistent by baseline eGFR albuminuria subgroups. And irrespective of whether patients were using or not using SGLT2 inhibitors, finerenone reduced the total GFR slope. Now, the important question is, of course, whether these benefits on GFR slope translate into risk reductions for clinical outcomes. So this first secondary outcome in our trial was a composite endpoint of 57% GFR decline, kidney failure, heart failure hospitalization, or cardiovascular death. This endpoint occurred in 134 patients in the placebo group, and it was reduced in the finerenone group. 110 patients in the finerenone group experienced this endpoint, resulting in a hazard ratio of 0.77, 23% relative risk reduction, with a confidence interval that didn't cross unity, and a p-value that indicated a statistical significant treatment effect. So we can now say that this 0.7 mils per minute per year and the difference in the primary endpoint total slope indeed translates into a clinical benefit. When we then analyze the kidney-specific composite endpoint, 57% GFR decline or kidney failure, we observed that this endpoint was reduced by finerenone, 125 events in the placebo group, 104 in the finerenone group, hazard ratio 0.78, but as you can see, the confidence interval just crossed unity and a p-value was 0.06. There were very few cardiovascular endpoints. Few patients were hospitalized due to heart failure or died due to cardiovascular causes. 16 in the placebo group, 10 in the finerenone group, hazard ratio 0.60, but the confidence interval is wide. Finerenone, as we would have expected, reduced albuminuria. This effect is fully present after 6 months of treatment. Reduction in albuminuria is 35% compared to placebo, and this effect is sustained throughout the follow-up period. Potassium increased in the finerenone group compared to placebo by 0.12 millimole per liter after 1 month, and again, this effect is sustained throughout the follow-up period. So a modest increase in serum potassium. Finerenone was safe and well tolerated in these patients. When we look at the adverse events, the proportion of patients that reported an adverse event was not different between finerenone and placebo. There were also very few events in the placebo and finerenone group that led to permanent discontinuation of the study medication. When we looked at serious adverse events, these are adverse events that require hospitalization or prolongation of hospitalization or lead to death. The proportion of patients that experienced such an event was similar between the finerenone and placebo group, and importantly, very few led to permanent discontinuation of the study medication, and very few led to death. And again, no difference between finerenone and the placebo group. Hyperkalemia was more frequently reported in the finerenone compared to the placebo group, but the difference was modest, 17% in the finerenone group, 13% in the placebo group. And as you can see, the clinical impact is also very small. Very few of these adverse events related to hyperkalemia led to permanent discontinuation. Very few were serious and none led to death. And on the right side of this figure, you can see that the number of patients with a potassium value greater than 5.5 or greater than 6 as measured in the central laboratory were more often observed in the finerenone compared to placebo group. So to summarize, FIND-CKD was a global phase 3 trial that met its primary and key secondary endpoints. Finerenone compared to placebo reduced the mean rate of change in GFR from baseline to month 32, and importantly, reduced the risk of the composite kidney cardiovascular outcome. We also showed that finerenone was safe and well tolerated. And although there was a higher incidence of hyperkalemia, the clinical impact of these events is minimal. So these were the data. Pleased to announce that you can read the details of the primary results of the FIND-CKD trial in the New England Journal of Medicine. And now I will hand over to Brendon, who will present the glomerular disease patients and an analysis that we specifically conducted in patients with glomerular disease, and we'll also talk about the clinical interpretation.
Well, thanks very much, Hiddo. We've heard from Hiddo that the effects of finerenone in FIND-CKD were consistent regardless of the cause of kidney disease, and now we're going to focus specifically on patients with glomerular disease, and this subgroup was pre-specified as a group of particular interest, and we prospectively collected information also on glomerular disease subtype. And what you can see in this slide here is that in FIND-CKD, there were 903 participants with an investigator-reported diagnosis of a glomerular disease, and this constituted 57% of the overall trial population and included 416 patients with IgA nephropathy, 215 with FSGS, 90 with membranous, as well as a range of other less commonly studied kidney diseases. Reflecting variations in kidney biopsy practices around the world, about 80% of patients with a diagnosis of a glomerular disease had their kidney biopsy performed to confirm that diagnosis. And so we also restricted analyses to those just with a kidney biopsy confirmed diagnosis of a GN. Here are the baseline characteristics of patients with a glomerular disease in FIND-CKD. And what you can see is the mean age overall was 51 years, approximately 40% were female, and approximately 60% were Asian. The mean eGFR was 49 mils per minute, and the median UACR was 840 milligrams per gram. And in general, patients with a GN tended to be younger. They were more likely to be female, Asian, have a higher GFR and higher UACR, as you might expect. And approximately 21% of patients with a GN were receiving an SGLT2 inhibitor at baseline. In patients with a glomerular disease, you can see here those who were allocated to placebo lost 4.2 mils per minute per year of GFR. In finerenone, this was reduced to 3.5 mils per minute per year, resulting in an absolute treatment effect on total slope of 0.7 mils per minute per year. So identical to what was observed in the overall trial population. And here on the right-hand side, you can see total GFR slope broken down into its acute and chronic components, again with a pattern of effect that was similar to the overall trial population. Here is the effect of finerenone on the primary outcome of total GFR slope by GN subtype. And what you can see here is that overall, the effect of finerenone in patients with a GN was consistent irrespective of what subtype of glomerular disease they had, whether it's IgA, FSGS, or something else, with an interaction p-value of 0.52. These results were entirely consistent when we restricted the analyses to biopsy-proven cases. Here is the effect on chronic slope in patients with a GN, so just excluding that acute effect. And you can see here again, entirely consistent results regardless of the cause of the GN, with an interaction p-value of 0.63. And in analyses restricted to biopsy-proven cases, again, also a consistent effect. Here is the effect on albuminuria with finerenone versus placebo in patients with a glomerular disease. And what you can see is there is an early reduction in albuminuria that is sustained over time, such that from baseline to 12 months, the placebo-corrected change in albuminuria with finerenone was 42%. That reduction in albuminuria with finerenone was seen across all glomerular disease subgroups with consistency of effect, although less precision in patients with MPGN owing to the very small numbers in this particular subgroup. Finally, we looked at the pre-specified exploratory outcome of kidney failure or sustained 40% decline in GFR, and we chose this particular time to event outcome, because it was the outcome for which we observed the most number of events in the trial, and thus provided us with the most statistical power to detect a treatment effect. In the placebo arm, you can see that there were 123 participants who experienced the composite kidney outcome. In the Fernando arm, this was reduced to 95, resulting in a hazard ratio of 0.74 and a 95% confidence interval of 0.57 to 0.97. Here is the safety profile for finerenone in patients with glomerular diseases. Overall, you can see that the drug was well tolerated with no imbalance of serious adverse events compared to placebo. Hyperkalemia was more frequent, but serious hyperkalemia events that were clinically relevant were uncommon overall at less than 2%. So overall consistent with the main trial population. So in this pre-specified exploratory subgroup analysis of patients with glomerular diseases in fine CKD, we observed that finerenone reduced the rate of GFR decline, reduced albuminuria by 42%, and was associated with a 26% lower risk of the composite kidney outcome of kidney failure or sustained 40% decline in GFR. And these effects were consistent regardless of glomerular disease subtype, consistent in analyses restricted to biopsy-proven cases, and also consistent regardless of SGLT2 inhibitor use, with the safety profile of finerenone overall in keeping with that was what was observed in the overall trial population. So now these results from the glomerular disease subgroup are also published online in JAMA, and you can find them on the JAMA website. And finally, what I'll do now is just to close, put these findings into context in terms of our existing standard of care. So when we're thinking about the effects of finerenone in fine CKD, it's important to contextualize this in the context of our currently available standard of care. So in fine CKD, as Hiddo pointed out, there was an overall treatment effect of 0.7 mils per minute per year. In Fidelio DKD, which was diabetic kidney disease, the effect estimate was identical, 0.7 mils per minute per year. And when we compare this to SGLT2 inhibitors in non-diabetic kidney disease, you can see DAPA CKD and EMPA kidney on the right-hand side, the effects of finerenone are at least as large as what is observed with SGLT2 inhibitors in non-diabetic kidney disease. These are really important and emphasize the value of implementation of these results now that we have observed them in dedicated trials in diabetic and non-diabetic kidney disease. So when we pull the available data across the program for diabetic kidney disease, Fidelio, Figaro with fine CKD, what do we find for effects on clinical outcomes? We see clear reductions in composite kidney outcomes, but importantly, we see reductions in the most important or the hardest kidney outcome of dialysis or transplantation, a 23% relative risk reduction. We see a 20% relative risk reduction in heart failure hospitalization or cardiovascular death. And finally, mortality outcomes, an 18% reduction in cardiovascular death and a 12% reduction in all-cause death. So really here we have a therapy that saves kidneys, saves heart, and saves lives. And so the data, or the totality of the data with finerenone in diabetic and non-diabetic kidney disease indicates that this is really a foundational therapy now for us across the spectrum of kidney diseases and across different levels of GFR and albuminuria. So finally, bringing us back to the paradigm or the framework for treating kidney disease that Hiddo outlined initially, whilst we've had fewer therapies in non-diabetic kidney disease, the totality of the data that we've presented at ERA and you've seen here online tonight indicates that finerenone is likely to be an important pillar of therapy, not only in diabetic, but in non-diabetic kidney disease to reduce kidney and cardiovascular and mortality risk. So in summary, CKD remains common and deadly. There are highly effective therapies, and finerenone now, along with those other therapies, can reduce kidney and cardiovascular risk. Fine CKD and Infinity, the pooled population of all the available data, demonstrates clinically relevant benefits for mortality outcomes, kidney and cardiovascular outcomes. And now our job really is to implement these therapies as soon as possible for the people with kidney disease to improve outcomes for millions of people worldwide. Thanks very much for your attention, and we're very happy to take any questions now. These results, including the pooled analysis, are also online in The Lancet, and very much looking forward to the discussion. Thanks very much.
So thank you, Hiddo and Brendon. I think this is really fantastic and good news for our patients. So I would like to start with a bit of provocative question. So Rosaire is much a PKD person. I am very much into AAV. So do we see any trial data soon also in these indications? I know it's both like patient populations with a huge unmet need in terms of cardiovascular morbidity, mortality, and also progression of CKD, of course.
I think when we set out to design this study, Andreas and Rosa, we were concerned that the mechanisms of disease progression in ADPKD might be different, that drive cyst growth, and that those might not be, ameliorated with MR antagonism, and that's why we didn't include these patients. But clearly, this is a huge area of unmet need, and I think it is incumbent upon us as a community now to do these trials, just as we've done them with SGLT2 inhibitors. Now, the French and German trials assessing SGLT2 inhibitors in ADPKD, we need to do this for other therapies now that are considered foundational, and I think that's an important job for us as a community.
Thank you. And thank you for this phenomenal trial and for the great presentation you did at the United Congress. I would like to ask you two brief questions. One is, do you think we need to wait for evidence for combined therapy, or can we go ahead with the three pillars without further evidence?
This is the big question going forward, right? Combination treatments, and we are going to see next year, probably at ERA, the first combination treatment, a combination of an endothelin receptor antagonist with an SGLT2 inhibitor. We have seen last year the combination of an MRA finerenone together with empagliflozin, but that was a surrogate endpoint. We'd like to see effects of combination therapies on clinical outcomes, and we're going to see those in the near future. And then the question is how and when to combine, for whom. Are we going to sequence these medications, or should we initiate simultaneous? What is the right sequence? Should we start with RAS inhibition, then SGLT2 inhibition, then finerenone? Or should we change our paradigm and start with the right drug for the right patient at the right time? So these are still important questions that we have to address in the future.
I think whilst we're waiting for those data, Hiddo, the other important thing to point out was that when we pulled the data, the effects of finerenone were entirely consistent regardless of background SGLT2 inhibitor use, suggesting that these effects are independent. So I think from a practical day-to-day, what is going to happen tomorrow perspective, for our patients who are high risk and that you are using an SGLT2 inhibitor and they have albuminuria, I think there's a clear role for finerenone in those individuals.
I want to follow up on this question. I mean, this trial is very important because it will lead to approval of finerenone, but for the clinician is already outdated, because for us, RAS SGLT2 is now standard of care, and this was not tested in that trial. So we don't know if there is an additive effect, and you mentioned the other trial that has tested this is probably the question for the clinicians currently have. So my question for you is, how long will the FDA still tolerate trials like this that do not really provide standard of care in the control group?
Well, we have to realize that we started these trials 5 years ago. So it takes about 5 years to finish with the recruitment period and the follow-up period. At the time we started these trials, there was just a little bit of evidence, one trial that demonstrated the benefit of SGLT2 inhibition. And still we find 17% of patients that were using an SGLT2 inhibitors. And what we presented is clearly effects that were consistent irrespective of background SGLT2 use. So I think from a practical perspective, as Brendon just said, we can add finerenone on top of standard of care, currently RAS plus SGLT2, and thus add finerenone. We know that that will lead to additional effects on albuminuria, and we anticipate that such effects will translate into effects on GFR slope and clinical endpoints. We don't have that evidence. We are collecting that evidence as we speak, also with the combination of a novel MRA with SGLT2 inhibition. But this is evolving, and we cannot do everything at once. We don't know what the standard of care will be in 5 years. If we would have known, we could have directly treated today. So this is always the conundrum we are in.
If you would speculate on the comparison between finerenone and the aldosterone synthase inhibitors. Surely nobody knows, but would you expect right now to see similar effects, or do you believe that the aldosterone synthase inhibitors, as they work by a slightly different way, may have other effects when it comes to kidney disease progression?
Look, I mean, it's a very difficult question to answer, and I don't think anyone
That's why
really,
we ask you.
honestly knows what the answer to that is. Theoretically, there may be additional benefits of an aldosterone synthase inhibitor because there is, again, experimental or theoretical data that aldosterone might exert deleterious effects through mechanisms that are independent of the mineralocorticoid receptor. Now, whether or not that translates into true clinical benefit, who knows? But it is one possibility. On the other hand, if you look at the glomerular disease data and the FSGS data, one might look at that and interpret the effects as being particularly prominent in FSGS. And we know the mineralocorticoid receptor is expressed on podocytes, and MRO activation drives parietal cell or podocyte proliferation and injury in glomerular disease experimental models. So, and maybe that is not addressed to the same degree with an ASI. So I think there are a lot of open questions here we don't know. So it's a long-winded way of saying I don't know, but you could look at it either way.
For me, I look at it a little different, maybe. For me, aldosterone synthase inhibitors are the big brother that are very potent. We've seen reductions, for example, with baxdrostat of up to 60%, 55% in people with chronic kidney disease. Large blood pressure effects, 8-9 millimeter mercury reduction systolic, but also an effect on potassium. Now, finerenone is modest effects on potassium, only 0.12 millimole per liter in fine CKD. Somewhat modest effect, smaller effect, but still nice effect on albuminuria, 35%. And because we know that if people with a lower GFR are more likely to develop hyperkalemia, I see baxdrostat as a drug, or the older aldosterone synthase inhibitor, ficerostat, as a drug probably earlier in the course of disease. And when patients have a lower GFR, you might want to switch them from an aldosterone synthase inhibitor to an MRA, which are slightly more friendly drugs. Little brother, nice little brother, friendly. And baxdrostat is the big brother that knocks you down, knocks the disease down. But when you have a low GFR, it may be also detrimental in terms of hyperkalemia. So this is how I view the two right now, but let's see what the data will tell us in the near future.
I think we are talking about luxurious problems now, because CKD becomes from, like, when I started my training, very boring to a very exciting field of medicine. So I'm really thankful for you guys doing all this stuff, and I hope you will join us next year again after Rotterdam. You already gave insights that we might have a new kid on the block, actually, with hopefully approval soon. Enjoy your evening in Groningen, enjoy the forum, and show Brendon around. We will hopefully be able to welcome you back next year and see you soon.
And we hope to welcome you in the Netherlands next year.
Good. We will come.
Thank you.
Thanks very much for having us.
And with this, we are back, and it's now our pleasure to hear from Dr. Dixon the results of his Commute A study. Dear Dr. Dixon, please.
Well, thank you for the opportunity to speak with you all today. So I'll be briefly focusing on what I was able to present at the late-breaking session on the readout from the Commute A trial's primary analysis. And the Commute A study was exploring the use of crovalimab, a novel C5 inhibitor, in the treatment of atypical hemolytic uremic syndrome, or AHUS, in adolescent and adult patients. So the study design for the Commute A study was with patients, as I've mentioned, with atypical HUS who were older than 12 years of age, who were either enrolled in a naive cohort of 41 patients who had not been previously treated with a complement inhibitor, or a switch cohort where they had been previously treated with eculizumab or ravulizumab, and that cohort was 41 patients, for a primary treatment period analysis of 24 weeks, after which time they could enroll into an extension study. And the primary efficacy endpoint of this study was complete TMA response, and that was defined as LDH being below the upper limit of normal, LDH being above the lower limit of normal, and at least a 25% improvement in serum creatinine. And crovalimab is engineered to be a very high affinity to C5 and also with low viscosity that allows it to be administered subcutaneously, which really represents the advance of this drug over currently available C5 inhibitors. So in the dosing strategy of this study, patients were given an IV loading dose on the first day, a subcutaneous dose on the second day, weekly loading doses thereafter during the induction phase, and then every 4-week maintenance subcutaneous doses in the maintenance phase of the study. These patients had extensive disease burden, with over half of patients in the naive cohort requiring dialysis at baseline, and over 40% of patients in the switch cohort having a history of kidney transplantation. And to cut to the chase, the COMMUTE-A study met its primary efficacy endpoint with 59.5% of patients achieving the complete TMA response endpoint, and this happened at a median of 12 weeks after initiation of treatment. Furthermore, all 17 patients who were on dialysis during in the naive cohort were able to discontinue dialysis, and those patients off of dialysis at the beginning of the study largely remained off of dialysis throughout the study. The drug was well tolerated with no unexpected safety signal, with the vast majority of treatment emergent adverse events being mild to moderate in severity. So I think to put this all together, crovalimab, being that it can be administered subcutaneously, represents an advance in the treatment of these patients. And this was mirrored with another study presented in the late-breaking session of crovalimab treatment of pediatric patients with AHUS.
Thank you so much. Atypical AHUS has been treated now with C5 inhibitors for quite a while. And clinicians have extensive experience with the use of eculizumab. So could you explain a bit more what's the benefit of this new C5 inhibitor? What's the difference, and what I gain in considering to switch from eculizumab or to choose this one?
Thanks for the question. So eculizumab and ravulizumab both have really transformed the care of these patients, and that it's gone from a disease with really quite dire outcomes to something quite manageable. But both eculizumab and ravulizumab require frequent IV infusions and represents a significant treatment burden to the patients. And the ability to administer this drug subcutaneously, even by the patient's own self or caregiver, represents an advance in the quality of life of these patients, and more efficient and beneficial to life circumstances.
Could you comment on the infectious risk, the need for vaccination that make our life with eculizumab a bit difficult?
Absolutely. So because this is a C5 inhibitor, it represents the same risks of meningococcal infection that other C5 inhibitors do. And so to enroll in this study, patients required vaccination against encapsulated organisms, including meningococcal bacteria, but also pneumococcal and Haemophilus influenza as well. Some patients also elected to use prophylactic antibiotics beyond the period where their vaccines were taking effect. So at least as a differentiation, this doesn't have any new safety concerns beyond what we know of C5 inhibition, but shares the same risks of those infections that we need to mitigate. That said, in the study, there were no no unexpected infectious safety signal in the data from the study.
Mm-hmm. So eculizumab just went off patent, and we have generic drugs available. Ravulizumab is still on patent. So this new drug, apart from the, let's say, addressing the unmet need of IV application, the sub-Q form, what can you tell us about it? Would it come with a interesting discount that would make it more attractive for clinician to consider beyond the IV sub-Q part?
Well, that's a great question. As far as like pricing and how this will work economically, I think that remains to be seen. It will certainly lower the costs, healthcare facility costs, so the overall cost to the patient and to the healthcare system, as patients are not using infusion centers for their treatments with that subcutaneous administration. I did, just in the interest of time, I did not mention that crovalimab also has affinity to C5 in patients with SNPs that render them resistant to eculizumab or ravulizumab. So that's another differentiator, that there are patient populations where this drug will work, where eculizumab and ravulizumab have not been successful.
I saw that on your trial you have authors from all world regions. As a European, I would just like to mention that European fridges are not as large as American fridges. And when you come with a sub-Q form that has to be stored in a fridge, the box size should fit European size fridges, because we have seen products that are so large that they are a burden by itself for European fridge owners.
Point well taken.
Thank you so much.
I've just one simple question. So you showed that in the switch cohort, you have roughly 40% transplant recipients. So my transplant recipients are very much focused on the drug they are used to. So they are really resistant to get switched from eculizumab to ravulizumab. So how did you, in practice, convince the patients actually to try a new drug for them?
Yeah, that is definitely a very tough population to win over with any new or different treatment. I would say that the self-administration, the freedom that provides, was a strong motivator for all patients. I didn't show the data, but in terms of preference, in both in the switch cohort specifically, all patients either had a preference for crovalimab over eculizumab or ravulizumab, or had no preference between the two. There were no patients that preferred ecu or ravu over crovalimab. So there's at least a little bit of preference data from the study that even those transplant patients were able to be convinced, let's say.
So thank you very much for your short presentation and this talk. So now we're moving on to the Mayo Clinic, and please, Fernando, maybe you can share your presentation for your study for Majesty.
So I like to thank Professor Hein for inviting me to present a short version of the presentation we did at the ARA regarding the Majesty trial, that is the obinutuzumab versus tacrolimus in primary membranous nephropathy. This is a study that was conducted across 49 sites in 11 countries. The design of the study was the patients were randomized to OB or tacrolimus. Now, inclusion criteria included patients who had age 18 to 75 with a UPCR of 5.5 grams based on a 24 hours urine collection for more than 3 months, or more than 4.4 grams per gram for more than 6 months, despite best supportive care, and they had to have a eGFR or creatinine clearance greater than 40 mL per minute. Now, patients who have been treated with calcineurin inhibitor or cyclophosphamide or any other biologic therapy during the 6 months prior to screening, or a B-cell before 9 months were excluded. They were also excluded patients who were resistant to calcineurin inhibitor or CD20 monoclonal antibodies. Now, patients were randomized according to the area, Canada, United States, and Europe versus the rest of the world, and they were stratified using anti-PLA2 antibody greater than 175 versus less than 175 units per ml. The primary endpoint was calculated, was a complete remission at week 104, defined with a UPCR less than 0.3 grams per gram with a stable eGFR defined as less than 15% reduction from baseline. It's important to this because this was a requirement for approval by the regulatory agencies. All right, so they wanted to have complete remission of proteinuria as the endpoint. And so it has to be designed as a superiority study, which which we know in other studies had been in fact the cause of major problem because of that requirement of the superiority study. There were a number of key secondary endpoints like overall remission, meaning complete and partial remission at week 104, complete remission at week 76, time to sustain eGFR reduction more than 30% at week 76, duration of complete remission. There was the patient-reported outcomes, and there was some secondary. There was a number of secondary endpoints, but the major one has changed in PLA2R at baseline to week 52, and the number of patients who got into a PLA2R negative, which was defined at that time as a PLA2R less than 14 units per ml. So here is the story. Patients are randomized 1-to-1 to receive obinutuzumab, and now that we are talking here, I can freely say the names is not the best because everything is open label, but they was creation at them as an open label therapy. So patients will get obinutuzumab at day 1 and 2 weeks later, and they would get obinutuzumab repeated. Everybody would get OB at 6 months. All right. And the tacrolimus was started at a dose of 0.05 milligrams per kilogram, and the dose was increased to get to a target level between 5 and 7 nanograms per ml. There were a number of what's called escape criteria. In other words, if patient, and according to, I didn't show, I'm not going to show you this, but according, for example, at week 24, if the patient had a proteinuria decrease of less than 25%, but had a UPCR greater than 3.5, that patient would be considered to be in the escape and will get 2 doses of obinutuzumab. If at week 52, the proteinuria was less, the reduction was less than 50%, and the UPCR was more than 3.5, then they will be again treated with 2 doses at baseline and another 2 doses at 6 months later. And of course, if the tacrolimus, the same thing happened. If at 24 weeks there was reduction of less than 20, there was considered failure, and the patient was then given rituximab OB, 2 doses at baseline and 2 doses a week later, at 6 months later. And if the patient had a relapse in between, then he would be again retreated with obinutuzumab. Now, the primary analysis was week 104, but the study continues. There is another study ongoing. That's the long-term follow-up period. There's another 2 years that is also looking for efficacy as well as side effects. So this is how the study turned out. There was 142 patients. They were randomized, 72 to OB and 70 to tacrolimus. In the complete week 104, you can see that in the OB, 20 of those patients had met the escape criteria versus 42 in the tacrolimus, meaning that week 104, we had 68% of the OB still available versus 29 in the tacrolimus arm. Now, this is what I just to show you what happened. The OB at 24 weeks, we had 11 patients that was went to the escape. The tacrolimus arm was 10, and you can see the others week 20, 52, 52 to 100. So I just want to take, because I think it's a little complex, and we didn't have time at the ARA to show that. Remember, I said every patient got treated at week 24 with another 2 doses. So then the issue is that the escape, in fact, there was is the name given if the patient got treated, because they were going to be treated. So you could say, well, are you talking about escape for now? Everybody got treated at 6 months, true. But the reason why they was named escape is because if you were in the escape criteria, this gave the investigator the possibility of to continue to giving OB subsequently at a later time point if he felt that was indicated. This is the baseline characteristics typical of a members of nephropathy population with age around 50 years of age, 70% male, and they had 30% with previous immunosuppression with preserved kidney function, EGFR greater than 80 mL per minute, in heavy proteinuria with around 10 grams per 24 hours. And the PLA2 was positive in about 75 to 80% of the cases. And in 30% of the cases, this group was considered very high PLA2R, more than 175. So this is the primary outcome of the study. You can see that at week 104, 37% of the patients treated with obinutuzumab reach the primary outcome that complete that UPCR less than 0.3 together with a baseline with a EGFR stable that was greater than 85% from baseline, and but versus 6 in the tacrolimus, which make a delta of 31% favoring OB. I just like to clarify one thing, that the patients, despite the escape protocol, etc., patients were the statistical analysis was done as per patient allocation at randomization. All right, so of course that will have given an advantage to the tacrolimus, because some of the tacrolimus they got, as I show you to you, they got escape, they got OB, but it still doesn't matter because also the OB got a little bit push up, so they equate each other. But it was not that they changed the randomized. The analysis was by how they were randomized at baseline. Now, just the second figure here is just to show you the difference. If you had used the same criteria as the mentor criteria used a different criteria for response. It was response of complete remission, meaning proteinuria less than 0.3 grams per 24 hours, together with a serum albumin of 3.5 grams. If you use that, and of course the complete remission rate at 104 in mentor was 35%. But if you use the mentor definition in the Majesty study, you get even like close to 50% response. But it doesn't change for the tacrolimus. And this was true even in patients with high anti-PLA2R levels, and of course the low PLA2R. So it made no difference, the patient, the same number of remissions. And of course, OB was associated with prolonged maintenance of remission compared to tacrolimus. There were only 6 patients in the OB group versus 21 patients in the TAC that relapsed after having achieved a complete and partial remission at week 104. And also OB, the mean time to relapse was not reached, but it was 87 weeks in the tacrolimus. So the bottom line is that 4 doses of OB provide rapid and lasting clinical benefit. The adverse event, there was no unusual or unexpected adverse events. There were 2 deaths, but one in the OB, one in tacrolimus, but one death was due to a heart attack, and the other was a COVID, because remember this trial was done during the COVID. It started during COVID, but grade 3 or 5 or any other special, with exception of infusion reactions, were not more common in OB then. So the conclusion of the OB that the study is that OB demonstrated superiority over tacrolimus in achieving complete remission at week 104. OB was superior to tacrolimus in complete overall remission at week 104 and complete remission at week 76. induce remission in the majority of the patients, regardless of the levels of anti-PLA2R antibody, increase the time of relapse, and no safety signals were identified. So that's what I have to present.
Thank you. Thank you very much, Fernando, for this outstanding trial. Well, I'm not an expert in membranous nephropathy, but there is something that is always a concern when a trial is designed for such a specific group of patients with this criteria, then the HTA usually approves it for this subgroup of patients. So do you think that really, once it gets licensed for membranous nephropathy, should only be used for patients with this high amount of proteinuria, or maybe it can be scaled down to lower proteinuria, even but still resistant to previous therapy? What do you think?
Yes, but remember that we know that in membranous nephropathy, if you don't have, this is historical data, but if you have low-grade proteinuria, you usually do very well. That's why KDIGO guidelines used to say that patients who have less than 4 grams of proteinuria, you don't give them immunosuppression, you just treat them conservatively, because usually they do very well. Now you follow them, because a lot of, in fact, Michel Claudinevich showed that I studied from Toronto like years ago, maybe 15 years ago. If those patients who present with low-grade proteinuria, 70% of them will progress to high level of proteinuria over the following 2 to 5 years, all right? But this, on the other hand, it tells you that the other 30% did not. So this group in low-grade proteinuria is something that especially if they have normal kidney function, which is normal, the majority of the studies they present, as you can see, they are different from other studies like IgA. They have all those patients have preserved EGFR. So if they present with low-degree proteinuria as a presentation, and they have normal, so what I do at Mayo, I just watch them. I don't do anything. Now, this is not to say that if a patient has a relapsing disease, because let's say the patient has been treated with whatever, has been in remission for the last 10 years, and now come to you. We know that a year ago proteinuria was 150 milligrams per 24 hours, but now the patient comes with 2 grams of proteinuria, and if his PLA2R positive was negative, now had a PLA2R of 25. Well, then I'm not going to wait. I think that at that time I am entitled to treat them, but this is in a relapsing situation, not in the first presentation. I don't know if I answered you with the question.
Yes, thank you.
I don't think that the FDA, I don't know how to do, if they approve. I think they are going to approve. I don't think the FDA is going to put a level of proteinuria. So I think it's unlikely that they will say for patients we have, but I don't know.
Dr. Segelmark, you have a question.
Yes, thank you very much for presenting this very interesting study, and I do not at all question your results, but I just wonder about the dosing of tacrolimus. When I use CNI in nephrotic syndrome, I usually go for a much higher trough levels. In tacrolimus, I would go for about 8 to 10 to start with, and then maybe lower it after I see a response. But here you had only 5 to 7. Do you have any comment on that, or are there any general recommendations that I don't know about?
That is what in fact, if you go to the KDIGO guidelines recommendation, I think the KDIGO guidelines, if I remember, they are about, I can look at that, but you can look at that. Gunnar can look and check and then confirm, but I think the KDIGO guidelines, or while I'm talking, Andreas can look at the KDIGO, but I think the KDIGO guidelines recommend a level between, I think this is the level that the KDIGO guidelines recommend, 6 to 8. It's not certainly greater than 6 to 8 nanograms. And this, in fact, is a level higher than a little bit higher by 1 milligram, I think, that what Praga did in the Starman. That target, I think, in the Starman was, I think, 4 to 6 nanograms. I like to mention that when we did the mentor study, we used cyclosporine. And I don't have, of course, I don't have this slide to show you that, but in the mentor study, the crucial, those patients were designed because Majesty was equal. It was a reflection of, was a copy of a mentor. The difference that one was rituximab versus and cyclosporin versus OB versus tacrolimus. But one of the observations from mentor is that when we did when we look at the kidney function of these patients, the most important thing I would say about this is that even when those patients were without, because they got it and then they came off. And one of the things that that we saw is that in the rituximab arm, the serum, the creatinine clearance improved to 100% at 2 years. So this was, you see, we gave at that time, what we thought it was between aiming for a blood level between 125 and 175. But you can see that in the rituximab arm, at the patients at 2 years, the clearance went down from 93 to 100 mL per minute. But in the cyclosporin, they came with an even better, this is not eGFR, this is quantified creatinine clearance, about 98 mL per minute. And you say, but look at that, at 6 months, clearance went to 75 to 71. You say, well, not a surprise, you are getting a calcineurin inhibitor with nephrotoxic, not so sorry. But remember here, they stop, all right? And then 18 months and 24 months. So this here, they have been at least 10 months with no calcineurin inhibitor. But you see that at no calcineurin inhibitor for 10 months, the quantified creatinine clearance is below the baseline of 91. So meaning that there was significant nephrotoxicity in those patients. So that's why we try to avoid higher dose of tacrolimus, because what we have seen in mentor that if you do quantify clearances, at least that's what we observe, there is significant nephrotoxicity that is not reversible, at least not in the first year after you discontinue the drug.
Fernando, I want to mention also this. I mean, after you published the mentor trial, I considered it unethical to give a patient cyclosporin because you reduce proteinuria, but you destroy the kidney. And I think this is a very strong argument against everyone that wants to approve drugs based on proteinuria only. So with the current Majesty trial, again, I find the control group very informative and important. I know at ERA you were questioned about that control group, but I found it a pure gold because basically it tells me that even tacrolimus, even if it's not nephrotoxic like cyclosporin, it came with a significant relapse rate, which you could completely avoid with a B-cell targeting therapy. That's why I hope that the FDA and also the EMA will finally approve a B-cell targeting therapy because they are approved for all other autoimmune diseases. We need that for membranous nephropathy too, because it's just another autoimmune kidney disease that deserves a B-cell targeting therapy. And that we finally stop that nonsense giving calcineurin inhibitors to people that need a B-cell targeting therapy. The only problem was it was all off-label up to now, and we were not allowed to prescribe it before having tried a calcineurin inhibitor. And the only one approved in my country is the nephrotoxic one. So thanks for doing this trial because it will really help us clinicians to finally give a B-cell targeting therapy a first line to these people.
I like to also mention, thank you, Joachim. I do also mention because one of the questions that was asked, the question that was asked is that why didn't we should, I mean, if the rituximab, why should we not do the test OB versus rituximab? And of course, that will be the correct scientific question to ask, you know, is while you do the, but remember that the idea was to get FDA approval. And the FDA required a superiority, all right? Now, by the time, we are in 2026, but by the time this study was designed, first of all, to get superiority, you have to do a power calculation. But to have a power calculation, you have to do a power calculation based in at least some data. There was no data. I mean, we had 3 cases that we reported with Latenzen, and there was about 8 cases from Los Angeles of using obinutuzumab in membranous nephropathy. But all those patients were in rituximab-resistant membranous nephropathy. There was no report of rituximab or OB used as first-line therapy in membranous nephropathy. So to do the power calculation. So therefore, if you do then you have to be very conservative because you are worried about it. You cannot say, all right? So if you do a conservative and you do the power and you do like you say, well, rituximab was 35%. Let's say we go for a 10% superiority, all right? 45%. Do the power calculation. That required 1,005 patients to be randomized, all right? So that's why it was not viable to do this study. That's why, yes, and that's why I participated, because I would be simply telling the patient, I think you are helping us to get this drug approved, because without this, the insurance company are going to continue to deny, and this, and don't worry, we will have these rescue therapies. If you, in 6 months, you don't improve, we take you off, whatever. So, but that was the idea. So sometimes the perfection doesn't help, because you're waiting for perfection, you may not have a study.
Thanks so much, Fernando. So before we switch back to Europe now, thanks to the 2 of you, both Dr. Dixon and Dr. Fervenza have to see patients, because in the States it's very early afternoon and not early evening like here in Europe. So they might leave us earlier. Thanks so much again to the 2 of you. Now we go to Sweden, to Dr. Segelmark, and we're thrilled to learn about Good Eyes 02. And I hope I pronounced the study name correctly, Mårten.
That's fine. Thank you very much for giving me the opportunity to present the data of the Good Ideas trial here again after the ERA meeting. And I do this on behalf of all the co-investigators and of the sponsor Hansa Biopharma. In the Good Ideas trial aimed at testing imlifidase in anti-GBM disease, and imlifidase is the medicinal product based on the streptococcal enzyme Hiddo. And Hiddo is an enzyme with extreme specificity for IgG, where it binds and cleaves at the hinge region, and it depletes the body of all circulating IgG within a few hours and leave the body completely deplete of circulating IgG for several days. And that, of course, also includes all anti-GBM antibodies that are the driving force in anti-GBM disease. We had previously tried Hiddo in an open-label phase 2 study and saw promising results. Here is the outline of the Good Ideas 2 trial. Main inclusion criteria were circulating anti-GBM antibodies and an eGFR below 20. And main exclusion criteria were anuria for more than 24 hours. 50 patients were randomized 1-to-1 to either start treatment with imlifidase or to start treatment with plasma exchange. Both treatment arms received intravenous cyclophosphamide and corticosteroids. Primary outcomes was renal function elevated by eGFR at 6 months, and the key secondary endpoint was the proportion of patients that had functioning kidneys at 6 months, which was defined as no dialysis sessions in the prior 4 weeks. Here are the baseline characteristics of the patients in the study. As you can see, they were well balanced when it came to sex, age, and ANCA, but there were severe imbalances when it comes to obesity, smoking habits, comorbidities, and also differences when it comes to eGFR at start of therapy and the histological damage, where the percentage of normal glomeruli was much less in the imlifidase arm. On the other hand, in the control arm, there were more anti-GBM antibodies, at least the median levels. As expected, imlifidase led to a rapid decline in anti-GBM antibodies, giving a substantial difference in the area under the curve for the first 2 weeks when it gets to exposure to the toxic anti-GBM antibodies. However, this did not lead to a significant difference in the eGFR at 6 months. It started a little bit lower in the imlifidase arm and ended a little bit higher, but the difference was not significant. And there was no difference in the proportion of patients that were free of dialysis at 6 months either. So what was the reasons for this? Yes, when we looked at the main prognostic factors that has previously been published, which is the eGFR and the number of normal glomeruli, and if we divide the patients into categories based on these factors, we can see that there were much more patients in the bad prognosis group for imlifidase and much more patients in the good prognosis group in the control arm. And this you can also see when you look at the results, where you can see that most patients in the good prognosis group were dialysis free at 6 months, while there was a significant, or not significant, but there was a difference favoring imlifidase when it comes to the bad prognosis group. But overall, the imbalances to begin with ended up, so there was no difference in the total outcome in the study. We also saw what is maybe a signal when it comes to the need for respiratory support, where patients, there were more patients in the control arm that needed CPAP and ventilator, and the control group also needed more transfusions during the first week when there was a difference in autoantibody levels. So to conclude, administration of imlifidase in combination with standard of care was well tolerated, a good safety profile in keeping with previous trials with imlifidase in other indications. We could also see that implementing this treatment regime combined with vigorous plasma exchange led to much better results than can be seen in previous cohort studies. We had expected a renal survival in the control arm of about 20%, but it was instead 60%. Initiating the treatment with imlifidase led to a rapid decline of anti-GBM antibodies and a less need for plasma exchange, and the less need for pulmonary support and transfusions, but we failed to meet the primary and secondary key outcomes, which was eGFR and need for dialysis at 6 months. However, as I said before, groups were not balanced when it comes to eGFR, histological risk factors, and comorbidities, obesity, and smoking. So in other words, the drug seemed to work, but the study failed. Here are the list of the co-workers.
Thank you very much, Mårten, and thank you for this brave trial, because this is such a devastating and rapid disease that it's really brave to try treatments, but it's absolutely needed. I wanted to ask you if you really think that the imbalance in these baseline characteristics may explain the results. Do you think that if you could have fixed that, or in another trial, that would change the results? And if not, I mean, do you still think that for a certain subgroup of patients that may be a useful drug, for example, for those with more pulmonary involvement?
Well, I mean that now we go from facts to what I believe, and of course the trial. I mean it will be very difficult, at least to say, to get the license based on this trial, and it's also very difficult to get someone else to do it, a new trial after that. But considering that we had with the results we get in the control arm. Sample size has to be bigger. But if we would see the same differences, I mean, if I go back to this slide here, and you can see there is here 25% better in this group and 26% better here, and sort of similar here to the right. If that would hold through, if that is telling us the truth, it is doing better. Yes, that would have been enough to get superiority for imlifidase, but you probably would need twice the size to get that statistically significant.
I would like to ask you, we are very much focused now on eGFR, and we believing in this based on the experience of trials with thousands of patients. We know that eGFR is notoriously poor marker when compared to measured GFR, and there's a variability of 30% both directions, which may be something you can tolerate in a large trial, but which may kill you in a small trial. So do you think that eGFR maybe is the wrong way to test efficacy in a small population of a rare disease, where maybe more or other endpoints like dialysis on off or so would be something that would be better because not so variable or depending on small changes in serum creatinine at the end, which are not reliable eventually.
Actually, it was in the protocol as a secondary analysis to have creatinine clearance, but unfortunately, the co-investigators were not able to deliver that on all patients, so we cannot really analyze that, and that so we had 24-hour urine collections as mandatory in the trial, but we didn't get that from all patients. So yes, we wanted to see if we could validate the eGFR with creatinine clearance differences.
Would you think that maybe measuring GFR is something we do not necessarily do in our clinics, but in a rare disease setting could help to demonstrate efficacy in such a trial? Because I'm a bit concerned that here we give away a potent drug simply because in a small patient population that endpoint may not be as reliable as we are used to from large population.
Yes, I agree with you. But we saw no. I mean, it's to do iohexol or some sort of clearances in a disease like anti-GBM disease, where you have an acute setting and you need plasma exchange, you need cyclophosphamide, you need renal biopsy, and you maybe need ICU in some patients. It's very difficult to begin with. And everything such as the 24-hour collection that we asked for was not done at all hospitals in the study.
It's also difficult in terms of practical issues because some patients have oligoanuria, of course, and so I think it's not 100% easy to do it. I think, Mårten, I mean, these results speak to itself. So if I've heard that in China and in Japan, they have other streptococcal peptides, which are very effective as well. If you would redesign the trial, would you just focus on those with this low proportion of normal glomeruli and the low GFR to start with, and then have a bigger sample size to get a positive signal?
Yes, I mean, if they would ask me, I could give them several advice. So yes, that would be one thing that I would probably. I mean, we did increase the sample, the inclusion criteria compared to the Good Ideas 1 trial from 15 to 20, and it would maybe have been better to go the other way. Recruitment wasn't really the problem in this trial. We actually were ahead of schedule for completing the trial. We could have been more restrictive when including the patients. And of course, now knowing that standard of care is a very good result if you have an eGFR above 10, and we cannot wait until we have histology because you need to start treatment. Then you have to exclude patients maybe after you have the histology from the analysis.
No, it's a definite an issue if you have such an acute rare disease, you know, how to stratify basically patients. And I mean, every one of us probably was very disappointed to see the press release. And, you know, I'm just asking myself what's next in this disease, because we really need some innovation as well, right?
Yes, we definitely need some innovation, but we also, I think this trial shows you need to be aggressive with the standard of care. You cannot give up on forehand. And you should really see that you start treating these patients very, very quickly.
Mårten, what would you think about using a complement inhibitor in the acute setting?
I think that's, I mean, there was a poster about that at the ERA from China, where they didn't really use it early on. They started about after 4 weeks. I mean, that complement system is involved. But I don't see that would be really better in the acute setting than imlifidase, but maybe the combination.
There is a eculizumab trial, at least registered at clinicaltrials.gov from Beijing, where they.
Yeah, I mean, it was presented at the ERA.
So, but it was not upfront, Mårten, right? That was given after a period of time, I think, after patients were already stable.
That was after 4 weeks, but I don't think there is any other eculizumab trial listed, except for that one.
Thank you very much for this discussion. It's great to have you here. So now we will go on to Lisa, who will present us the TURING study.
Thank you very much for asking me to present the results from the TURING trial, which I'm presenting on behalf of all our investigators and collaborators. This trial recruited people with primary minimal change disease and primary FSGS, which are the commonest cause of primary nephrotic syndrome and affect about 10 per million population per year. Lots of patients, so more than 80%, will respond to high-dose prednisolone in terms of achieving remission, but about 60% will either frequently relapse or are steroid dependent. Data from RADAR shows that both conditions are associated with significant progression to end-stage kidney disease, and even minimal change disease, which we generally thought of as quite a benign condition. 13% of patients will end up with kidney failure at 10 years after diagnosis. So that was the background for why we did the TURING trial, with a view to trying to maintain remission in these patients, because we know that maintaining remission reduces the chance of progression of their kidney disease, and also to try to reduce the exposure to high-dose steroids that they have with recurrent relapses. So we recruited adults with de novo or relapsing minimal change disease or primary FSGS, and they were recruited at the time that they presented or relapsed with their nephrotic syndrome. All patients received prednisolone at 1 milligram per kilogram. It's capped at 60 milligrams until they achieved either complete or partial remission when their prednisolone was weaned. And the prednisolone was weaned according to a pre-specified regimen, which was selected by the investigator at the time of randomization. Regimen 1 was a standard KDIGO wean. Regimen 2 was weaned much faster. So the KDIGO wean was over 16 weeks, whereas regimen 2 was over 8 weeks, which equated to almost a gram less of steroids in total. So patients were randomized to receive either rituximab or placebo So 2 1-gram doses intravenously 2 weeks apart at 0 and 2 weeks. And then if they were still in remission at 26 weeks, they had another dose. If patients relapsed, they were unblinded. And if they were in the placebo group, they were eligible for the open label phase, where they restarted prednisolone and they had open label rituximab. We followed patients for a minimum of 18 months, but a lot of patients for longer than that. So we recruited 149 patients, of whom 122 achieved remission by week 16. The remission rate was 93%, but if we include those who withdrew due to steroid side effects, it was 86%. So the median follow-up was 2.3 years, or 140 weeks, and we had 67 relapses during follow-up. 38% of the patients we recruited had FSGS, and 34 patients had de novo disease. Those are the baseline criteria, which were pretty equally balanced for most of the baseline characteristics. We'd stratified for disease type, presentation, and prednisolone withdrawal regimen. So we had a mean age of 53 years in total. So the primary endpoint for the trial was the time from remission to relapse. In total, over 140 weeks, we had 45 relapses of 59 patients who achieved remission in the placebo group and 22 of 63 in the rituximab group. So the median time from remission to relapse was 23 weeks in the placebo group and wasn't achieved. The median was still in remission in the rituximab group at the close of the trial. Of the 45 patients who relapsed in the placebo group, 41 went into the open label extension, where they received rituximab, and then their disease course mirrored very closely that of the rituximab arm of the main phase of the trial. We did a number of subgroup analyses. So we analysed by disease type, and we found the odds ratio of 0.23 was the same whether patients had minimal change disease or FSGS. So 80% of the minimal change disease patients relapsed in the placebo group compared to only 40% in the rituximab group. For FSGS, 68% in the placebo group and 26% in the rituximab group. We also analysed according to the regimen of prednisolone wean, so the KDIGO standard wean over 16 weeks, which is shown in blue, or the accelerated wean over 8 weeks, shown in gold. And you can see that whether you had regimen 1 or regimen 2, you had the same relapse rate for the rituximab group and also within the placebo group. So we wanted also to know whether giving rituximab affected the time to achieving remission. And for this, we included both complete and partial remission. And we found no difference in the time to achieving complete or partial remission, whether patients were treated with placebo or rituximab. And also there wasn't a difference in terms of disease subtype. So the FSGS lines are in blue, the minimal change disease are in red, solid is rituximab treated, and dotted is placebo. However, when we looked at patients achieving complete remission, we did see a difference in the FSGS patients treated with rituximab. So those are the blue lines here. So the solid blue line is FSGS patients treated with rituximab, and the dotted line is FSGS patients treated with placebo. And patients with FSGS continue to achieve complete remission up to a year after starting in the trial. In terms of adverse events, we collected adverse events of special interest, and these were those related to either the state of nephrotic syndrome or to immunosuppression. Overall, there were more AESIs in the rituximab group than the placebo group, but the rituximab group were followed for more than twice as long as the placebo group. So when we adjusted for the time under follow-up, the rate of adverse events of special interest was the same in the two groups. And the number of SAEs was equivalent in the two arms as well, with 18 in the rituximab group and 17 in the placebo group. Almost all patients coming into the trial when they were nephrotic had hypogammaglobulinemia, but once they achieved remission, there were very few that developed hypogammaglobulinemia subsequently in either arm. So in summary, rituximab is a safe and effective treatment to delay relapse in patients with primary minimal change disease and FSGS. 3 1-gram doses given intravenously over 26 weeks can maintain remission for more than 2.8 years. Rituximab increases the proportion of FSGS patients achieving complete remission, and a faster prednisolone wean may reduce exposure and side effects to steroids without increasing the relapse risk. And I'd just like to finish by acknowledging the many people who are involved in this trial. Thank you very much.
Thanks, Lisa, and also thanks to Megan, although she's not here, because this is really a game-changing trial, in my opinion. So, will you use now rituximab alongside steroids as a first-line treatment for minimal change disease and FSGS in your patients?
Well, that's a very good question. So I didn't show you the data for that. But in the placebo group, in the de novo patients, 53% of patients relapsed, which was perhaps slightly lower than we were expecting based on the literature. But the relapse rate halved in those treated with rituximab. So it's only 23% in the de novo patients treated with rituximab. So I think using rituximab for de novo patients is justified. We had a little poll amongst ourselves for who would go for rituximab as first line treatment, and I think we all thought that we would, because I think the morbidity associated with both high dose steroids and the nephrotic syndrome, is quite marked, and the risks of rituximab are quite low. I think the referens trial would be really helpful to provide more data on that. So I'm looking forward to seeing those results when they come through.
Yeah, it answers a slightly different question. What about quality of life of your patients? Did you measure that as well, systematically?
So we've got a lot of quality of life data, and we are in the process of doing a health economic analysis, which will incorporate quality of life. So the quality of life is largely driven by the steroid dose. So I think that's the kind of overwhelming signal from what we've looked at the moment, but we'll look in a bit more detail at that too.
Another important question is always mitigating serious infections. Did you use systematically trimethoprim sulfamethoxazole as a BJP prophylaxis?
We did. So it wasn't mandated, but it was recommended, and almost all patients received it for at least the first 6 months of the trial, whilst on high dose steroids. And I think that's the time when it's most important when patients are treated with the steroids. I think that's what's driving the PJP risk rather than rituximab itself. We'd also recommended considering TB prophylaxis for patients who are considered to be at risk.
Yeah, maybe I can make a question. When it comes to rituximab, there's the UK and the rest of the world, because in the UK, rituximab seems available, and in the rest of the world, it's off-label and essentially not available for the treatment of these diseases unless you do a lot of paperwork. So I noticed that you have limited your patients to nephrotic patients with minimal change in FSGS, and we just had Spasentan approved for non-nephrotic FSGS. Do you think that the clinical distinction between nephrotic and non-nephrotic is good enough to distinguish between people with autoimmune podocytopathies and non-autoimmune podocytopathies? Or I think we stopped treating lesion patterns, so we would like to know if someone is autoimmune or not, and then if it's autoimmune, we may consider steroids and rituximab.
Yeah, I mean, we've based this pretty much on the KDIGO guidelines, which say if a patient's got nephrotic syndrome, then consider a trial of immunosuppression. So that's where we were coming from. I think the other thing to remember with our trial is that our primary endpoint was time from remission to relapse. So the patients who achieved remission and stayed in the trial had already shown themselves as being steroid responsive. So I think in answer to your question, I still think I probably wouldn't treat people who weren't nephrotic with high dose steroids and rituximab. I think I would, almost regardless of what the biopsy shows, I think I would base my decision on nephrotic syndrome. Partly we know outcomes are related to proteinuria. The higher the proteinuria, the worse the outcome is. So I think it's that sort of risk benefit analysis of how much immunosuppression you expose a patient to and what risk you're putting them at compared to their risk of developing end-stage kidney disease.
I mean, I like your line of argumentation. The problem is only now, at least in the US, that now sparsentan is approved. That means if you don't use sparsentan, you maybe have a legal problem and use the rituximab instead. So that's the question, how you would think how to navigate this.
I don't think they're mutually exclusive. I mean, we didn't mandate ACE inhibitors or not ACE inhibitors, but the majority of our patients were on ACE inhibitors. And I think certainly for patients with FSGS who take longer to go into remission, it makes a lot of sense to do what you can to reduce their proteinuria by non-immune suppressive means. I think sparsentan would be very useful in that category. I mean, whether in minimal change disease, when they're likely to go into remission within a couple of weeks, whether you would use sparsentan under that circumstance, I don't know. Almost all of our patients with minimal change disease achieved a complete remission. So yeah, I'm not sure I would in that group, but the patients with FSGS, more than half of them took more than 4 weeks to achieve a remission, and as we saw from complete remission, that took an awful lot longer. So I think sparsentan in those patients is totally justified. Once they're in a complete remission and their proteinuria goes, then you would stop it.
Thanks so much, Lisa. And now we go back to the venue of the last ERA Congress, beautiful Vienna. We're happy to have Gregor Bond for at least one study which is focused upon transplant patients, which is so important because we saw quite few new data on transplant patients in recent years. Gregor.
Thanks for the invitation to the Marcus at Home team, and thanks to the representatives of the ERA and NDT to present our data here on the TTV-guided trial. I speak on behalf of the whole European-funded TTV-guided team and the whole investigator team. So I'd like to start with the primary aim of the whole study. We wanted to personalize immunosuppression in kidney transplant patients. As you all know, since Symphony, we try to target our patients on an average of 6 to 7 tacrolimus through level, but still we have infections of over and under immunosuppression, mainly infections, malignant diseases, and rejection on the other hand. And we tried to search for a way to optimize this and came across the TORC virus as a potential solution. What is TORC virus or TTV? It's a virus that is detectable in the blood of basically all kidney transplant recipients. Most importantly, it causes no disease, and it reflects the immune function of its host. So TTV load in the blood associates on one hand with infection and on the other hand with rejection. And we look at our hypothesis here on the right-hand side. We think that immunosuppression can be personalized by quantifying TTV. If TTV is very high, then we think this patient cannot really suppress the virus, and the immunosuppression might be too high. Then there might be an optimal level, and then there might be a range where TTV is too low, and there the immune system of the host is maybe too strong, is able to suppress the virus quite well. On the other hand, is prone to graft rejection. And we try to prove this hypothesis by the TTV-guided trial. It's an investigator-initiated, multi-center, patient and central assessor-blinded, non-inferiority, randomized, and control phase 2 trial. And it has received full funding by the European Commission and is registered there in the EU registry. So the cohort is mainly adult kidney transplant or only adult kidney transplant recipients, and all of them had a low risk for graft rejection and infection, mirroring the phase 2 trial, and all of them were on tacrolimus-based immunosuppression. So what we did, we screened these patients in the first 3 months after transplantation, and then in months 4 after transplantation, we randomized 260 kidney transplant recipients on a 1-to-1 ratio to 2 groups. The active or intervention group, in this group, the tacrolimus through levels were guided by TTV. And in the control group, the patients received tacrolimus according to local standard of care of the center. So I want to go in a bit more detail what happened in the active group. So in the active group, at every visit. The visits were every 6 weeks until month 12 after transplantation, so 7 visits in total. We measured TTV, and according to the TTV level, we adapted the tacrolimus through level, or the goal of the tacrolimus through level. If TTV was above the upper limit, we thought, well, this patient is over-immunosuppressed, and we went down with our tacrolimus target. If TTV was below a certain limit, we thought, well, this patient has not enough immunosuppression, and our tacrolimus goal went up. And then we had the golden middle here where no change happened. Our primary endpoint at month 12 was a compound endpoint, and it concluded infections, graft rejection, graft loss, death, and in the primary analysis also loss to follow-up. So these are the results. We recruited at 13 centers of 6 EU countries. The recruitment went on for 2 years and ended in May last year. We screened a bit more than 500 patients and could randomize 260, 131 in the TTV-guided group and 129 in the control group. This is the numbers of patients completing the trial. And then in the modified intention to trial analysis, this was our primary cohort of our primary analysis. We had 128 patients each. If you look now at the baseline characteristics, the groups are well balanced. Like always in transplant trials, and that is a pity, we have only 1/3 female patients. This is usual for transplant studies, but again, this is well balanced. And I want to mention here that most of the patients are from white ethnicity and Caucasian. And these are our primary results. So the primary analysis was the primary aim of the study was to show non-inferiority. And we did the primary analysis in the modified intention to treat cohort, 128 patients each. And here we had 45 events in the TV-guided group and 48 events in the control group. The compound endpoint was mainly driven by infections, as you can see here. There was only 1 rejection in each group, a borderline and 1 TCMR1B. No graft loss, 1 death in the TTV-guided group. This was non-immunosuppression related, and then some loss to follow up. And the difference of proportion between the 2 groups was -2.3%. And this is the confidence interval. And that's how we predefined non-inferiority. The upper limit of the 95% confidence interval had to be below 10. And this is given here. And by that, we can conclude non-inferiority, and the study met its primary aim. Having said that, we were not able to prove superiority. As you can see, only slightly minimal less events here in the TTV guided group. But there's some interesting data if you look at the secondary endpoints. If you look at the tacrolimus through level, here in blue, you see the tacrolimus through levels of the TTV guided group, and in red of the control group. And you can see between visit 2 and 6, the TTV guided group has had lower TAC levels. And if we analyze all the values during the treatment period here, then in a linear mixed model, this difference was significant. We had an average of 6.2 compared to 6.7 nanogram per milliliter of tacrolimus through level. Something else that was quite interesting, in the TTV guided group, we indeed had more personalization. So we had an average of 7 tacrolimus dose adaptation, not only at the visits, but during the whole study period, and only 4 in the control group. Again, this was significant. Of course, these are only secondary endpoints, and by that, only hypothesis generating. And one thing that was quite important, everybody will ask, well, you have here a bit lower tacrolimus levels, but what about safety? And we were lucky enough to have, in a lot of patient month 12 protocol biopsies, and could show there was no significant difference when it came to rejection according to BANF meeting report or molecular microscope by Phil Halloran's group, and not more than novo is in the TTV guided group. all the other adverse events, serious adverse events, or higher graded adverse events, or adverse events certainly probably related to tacrolimus were comparable in both arms. So that's my takeaway. I would say we've shown that TTV-guided tacrolimus dosing is safe in a low-risk group, mainly adult and Caucasian patients. And in this low-risk group, TTV-guided monitoring might help us reduce tacrolimus and to increase personalization. Thanks. That's it from my side.
As a naive questions, because I'm not a transplant expert, I wanted just to ask if TTV is something available everywhere where people are, where we do kidney transplants in the hospitals with something easy to do? Or?
Yeah, that's actually the nice thing. It's IVRDR approved for clinical use. It's a PCR. Every microbiology lab can easily set up. It's commercially available. It's about between 25 and 50 euros, quite a nice price if you compare to other biomarkers. And we have shown in another publication that you can implement it with really low inter-laboratory and intra-laboratory variability. The variability was only 0.2 log levels, and you have to, and this PCR gives log levels up to log 10. So if you compare to your regular CMV or polyoma PCR, it's very easy to implement.
And then do you foresee a larger trial to be sure this works? Do you think that's enough? Or?
Very good question. In a dream world, I would, but that's a matter of money. This was sponsored by the European Union. It's not a big pharma company behind it. And they sponsored this with 6 million euros for a trial to go on. We maybe even need more. And there's no public funder for that, I guess. We're now analyzing more and more of the data, and we realized that we could improve the trial protocol when it comes to endpoints. We see that most of the infections we were able to reduce were opportunistic infections. And so I would be able to shape the protocol better now. But maybe I don't have enough money. Having said that, there's another study going on, the Taoist trial from Olivier Tourneau. It's a national study in France, a 4-center study. And they use basically exactly our trial protocol, starting from year 2 to year 5. And that's maybe a good idea to pool our data then. It's easy to pool the data because it's basically the same trial protocol. And maybe we get more information out of this pooled data then.
I guess your TTV is also suitable to detect drug non-adherence, and maybe your study population was not represented. Did you test any drug non-adherent patients in your trial, and if, how many?
It's a very good question. We were dealing with adherence as well, or very much interested in adherence. That's why we accompanied the trial with a very intense adherence monitoring. We used the BASIS questionnaire and also electronic drug monitoring. We're still working on that data. But I have data from an adherence group defined by BASIS. And in this group, the effect was larger. So the patients that really stick to the protocol, the adherent patients, there the effect was about 4 to 5%, the difference between the two groups. So yes, if you look only at the adherence patients, you have a bigger effect of TTV guidance.
I need to say just a comment also to Lisa beforehand. I think, clinical trials led by investigators, this is really something everybody need to comment on, because this is really amazing stuff you're doing, and all of us know how much work it needs to set something up. 260 patients in this field doesn't sound a lot, but I knew, like, from my colleagues and from the readout, that this was really a major undertaking, and also all this trial visits the patients required actually. If you would design the trial again, Gregor, would you change something in the protocol? You mentioned you would probably focus on opportunistic infections?
Yes, some changes. So we see that the subgroups don't react in the same way. So maybe I would adapt the range a little bit according to sex or to age and other subgroups. I might do a little less interventions, but not because now we learned that TTV takes up to 2 or 3 months to reflect the immunosuppression. So 6 weeks might be too quickly to react. And in the end, this is data just got yesterday from the trial. Only about 35% in the TTV-guided group were within the optimal range. I think there's room for improvement to get more patients within this optimal range, and then maybe we see a bigger effect. Also, I would now maybe exclude from the primary endpoint deaths that are not immunosuppression related. It was a phase 2 study, that's why I wanted to include that, but maybe it doesn't reflect really what we can change with TTV. Also, there are some infections where we had no chance at the beginning. I analyzed every single infection and saw, well, there was, for example, a patient with an ileum conduit and 10 urinary tract infections during the study. I guess no drug in the world could prohibit this infection. So yes, there's room for improvement. Let's see how we can go on.
So do you think that measuring TTV is always basically one step too late? So you're reacting to the data change after you see it, after a couple of days, weeks? And so the damage is already done, or?
No. I can tell you how I use it in the clinic. Because in the clinic since 2016, 10 years now, I have it as a routine marker. And basically, we measure it every 3 months, every time a patient comes to our outpatient clinic. And then I go back in time. I have about 2 years of this patient. I see his history. I see his decorative through level. I see his TTV level. I see how he's doing clinically. And then I get a feeling what TTV level is ideal for this patient. And of course, as every biomarker, it is one piece of the puzzle. It is naive to think that one biomarker will solve the problem. We saw this with Outsmart, we saw it with urinary chemokines, and we noticed from the clinic, even C-reactive protein, which I heavily rely on, sometimes false positive and false negative. So I use it as a piece of the puzzle. I use it as a longitudinal parameter, and then it really gives me some information. During the study, I really learned that by looking at TTV, I was able to go very, very low with some patients, and I dared to go as low as the tacrolimus dose of a level of 2 or even below our threshold, and these patients were still doing well. So their TTV helped me also a lot. And non-adherence. We had very young patients, 2 or 3 lost their kidney. Then in retrospectively, I looked at their TTV level, and so it was always perfect, and then it dropped completely. And this was basically the time when they stopped taking the immunosuppression. I confronted them, and then the tears started and everything. It was devastating, but then it was a sign of non-adherence. So there is also a power of TTV, I think.
So many thanks, Gregor. We are already looking forward to the upcoming NDT webinar about TTV this autumn. So our sincere thanks to all of our distinguished guests and co-moderators for making this such an outstanding webinar. It's truly inspiring to bring together so many people who share such a deep passion for nephrology and a commitment to advancing patient care through research and collaboration. We would like to express our heartfelt gratitude to everyone who contributed to today's discussion. It has been a privilege to hear from so many leading experts and to share these exciting developments with our audience. Thank you all for joining us, and we are already looking forward with great anticipation to seeing who will be joining us next year for another remarkable edition of this event. We are looking forward to a great reunion in Rotterdam.